So we're presenting an abstract looking at recurrent mutations, specifically those in the B-cell receptor signaling pathway and in anti-apoptotic machinery in patients treated with venetoclax after treatment with another BCRi antagonist. These are actually data that come from the phase 2 study of venetoclax monotherapy in patients who either were treated with Ibrutinib previously or those who were treated with Idelalisib previously. The whole study cohort includes 127 patients, 91 of which were previously treated with Ibrutinib. Looking at the long-term clinical data, it's fairly similar to what has been published before with these agents. So overall, in both cohorts, we had a median progression-free survival of about 33 months, longer in those patients who were previously treated with Idelalisib, a little bit shorter in those previously treated with Ibrutinib. There it was about almost 25 months. We don't see any new safety signals with venetoclax monotherapy in this long-term follow-up either. One of the most interesting things that this study did is actually take paired samples pre-venetoclax and then at the time of relapse in those patients who relapsed, or in the patients who continued to respond. Many of them rolled over into an extension study, and there was a sample taken at the time of rollover into an extension study. So we have a cohort of patients who are progressed on venetoclax and a cohort that are still in remission. We looked at mutations in BTK, TP53, and BCL2 in all of these patients. Interestingly, we actually see that a couple of patients who had BTK C41S mutations prior to treatment lost it at the time of progression after venetoclax, which is really provocative information. Maybe you could think that some of these patients could be resensitized to a BTK inhibitor at least for a period of time. We see TP53 mutations acquired in a number of patients at relapse. And then looking specifically at BCL2 mutations, in the cohort of patients who was progressed on venetoclax, 30% of those patients were identified to have mutations in BCL2. 5 of those patients, there was only one BCL2 mutation, but actually in 8 of them, multiple BCL2 mutations were identified. In those patients who were in continuing remission, we still saw 11% of them have a BCL2 mutation. When we look at time to acquisition of a mutation, we see that the acquisition of BCL2 mutations tends to be a late event, both in the progressors and in the non-progressors. Most of these BCL2 mutations are subclonal, as has been previously reported. We especially see very low allelic frequencies of the mutations in those continuing responders, as you might expect. So I think that this is a really interesting study that continues to show that BCL2 mutations are associated with venetoclax relapse, again suggesting that these mutations potentially are going to be able to be identified prior to clinical relapse. And we don't know exactly how long that interval is going to be between when a BCL2 mutation can be identified and the time of relapse.